Namaskar friends, welcome back in continuity with the previous lecture of approach to a woman with hyperemesis gravidarum. We did complete till the onset of complications and now we will continue with the same topic, approach in a woman with hyperemesis gravidarum approach, and now we are discussing about the complications. The previous video's link is given in the description box and you can go through it also through the playlist. The description is given in the link is given in the description box. Now coming to complications, I just told you that what are the advantages, that she is having less risk of abortion, less likely to give preterm birth and less likely to have stillbirth. Now what are the complications? In maternal complications, there is nutritional deficiencies because of the poor oral intake. So nutritional deficiencies are the maternal complication. Weight loss, even the weight loss of more than 5% is the criteria that it is a severe form of vomitings of pregnancy. And another is dehydration, starvation, dehydration that is occurring and its complications. So these are the complications seen in mother. If it is severe persistent vomiting, she may develop Mallory-Weiss tear. Mallory in severe form, Mallory-Weiss tear. She may develop esophageal tears. Pneumomediastinum may occur. Then other complications like neurological complications like Wernicke's encephalopathy, may occur in a woman, which is, fortunately these are rare nowadays. But yes, with intractable vomitings and retching, what can happen is retinal detachment, then esophageal tears, pneumomediastinum may occur, and this Mallory-Weiss tear, they can occur. So these are the complications which should be kept somewhere in your mind when you are having an approach towards a woman with hyperemesis gravidarum. Now what else? Now coming to management, you have admitted her, you have subject her to various lab tests, you have assessed the severity by again I am telling you, this is important, PUQE score, and you have made all the differential diagnosis, you have ruled out other diagnosis, and now you have to initiate the management. What management you are going to do? First of all, restore her fluid and electrolyte balance. Okay, first of all these management, three principles of management, they will be going side by side. It's not like first you will be doing this, then second this, then third this. These are the principles, these are the heads on which you will be working. First of all, you will be restoring her fluid and electrolyte imbalance. The second thing what you will be doing is you will be restoring her biochemistry, her biochemical changes that has occurred because of starvation and deficiency of nutrition. You have to maintain her nutrition also. And third one is to start antiemetics to prevent further vomitings. Now for restoring the electrolyte imbalance, we will be giving her IV fluid. As she is having persistent vomiting, we will ask her not to take anything orally. So she will be kept in orders nil per orally. Then restoring fluid balance, around 3 liter of fluid is to be given. 1.5 you can say dextrose 5%. If you are giving, you have to give it this first point with thiamine. Don't forget this, otherwise you may precipitate encephalopathy. So, well, while restoring her fluid and electrolyte balance, if you are giving 5% dextrose, don't give it plain, add thiamine to the first point. And this remaining 1.5 is usually RL. You can add NS also, give combination of 1.5 liter. So, 3.5% D, 3 RL, or you can go with 2.5% D, 1 NS, 3 RL. In this way, you will be giving her 3 liter of intravenous fluid along with thiamine added to the 5% dextrose in first drip. Now, what next? If suppose on evaluation you find that potassium is low, then you will be adding potassium to her fluid, but that is to be only after consultation with the physician, and it is to be given very slowly as advised by the physician if potassium is found to be low in the these tests. Now, what next? After restoring this, initiating this IV fluid, restoring her fluid in electrolyte balance, you are also supposed to give antiemetics. These are the important drug in this case. Most commonly we give promethazine. It can be given either per orally or IV. As when we have started the treatment, we have kept her NPO. We can give small tablets per orally. If she does not tolerate those tablets, she vomits again, you have to start this IV. The dose of promethazine IV is 50 milligram IV, can be given up to 6 hourly. Always remember. Now, apart from these promethazine, prochlorperazine, chlorpromazine, doxylamine. Doxylamine is orally given. The dose is doxylamine in clinical practice, in OPD, this doxylamine succinate 10 milligram is usually given BD, okay, twice daily. But what happens if the woman is not responding? You can increase up to QID 4 times a day. This 10 milligram or 12.5 milligram doxylamine. This is the first treatment that we prescribe to a woman with hyperemesis gravidarum or severe forms. Now, metoclopramide, dopamine antagonist. Metoclopramide is also given, may be given. This is also first line drug, but it has got extrapyramidal side effects, and also the promethazine has sedative side effect. If woman is not able to tolerate these medicines because of the side effect that I told you, promethazine has sedation as a side effect and this metoclopramide has extrapyramidal side effects. Now, what next? The second line of treatment, if woman is not able to tolerate these first line treatment, is ondansetron. Ondansetron, now it is a category pregnancy class B drug. It can be given up to 8 milligram IV 8 hourly or even 6 hourly sometimes can be given. So, this is the second line drug. This is 5-HT receptor antagonist. 5-HT antagonist, ondansetron. It is a very potent antiemetic. It is also used to prevent vomitings of even during chemotherapy. So, it is a potent antiemetic, but it is a second line treatment. You just cannot start it with the first line. First line are promethazine or doxylamine or metoclopramide. If woman is not able to tolerate them, then you will be giving ondansetron, because it is a recent addition. It is pregnancy class B, so you can initiate it very easily without any hesitance. Now, what about the role of oral steroids. Role of steroids either orally or IV. You can give this, but what are the advantages if you are using steroid in your treatment? Now, during this stay in the hospital, there is no further benefit by adding these steroids. It's not that she will recover soon, or it's not that she will not have any complication. It doesn't have any that role, but definitely it has a role in reducing the rehospitalization of the women who are being treated for severe forms of emesis gravidarum or hyperemesis gravidarum. So, it reduces the incidence of readmission. So, these are methylprednisolone of up to 8 or 16 milligram twice daily, IV or orally is given for initial 2 days. The woman usually responds within 2 days, and then it is tapered over for 2 weeks, over 2 weeks. If a woman is having hyperemesis gravidarum at an earlier gestational age, suppose she is coming at around 6 weeks gestation, so it is advisable to add steroid also along with the antiemetics. But if she is coming, suppose in later part of first trimester, around 10 weeks, around 9 weeks, 10, 11 weeks, so it will not be of much help, because with time the hyperemesis will subside by itself. In early gestation, suppose 5 weeks, 6 weeks she is coming, so there are more chances that she may require rehospitalization. So, using steroid along with the antiemetics during her hospital stay this time will definitely reduce her risk of getting readmitted for the same complaint. So, in those cases we can add either IV or per oral steroids. So, these are the important things that you should remember. Now, one more thing that you should never forget, and if you mention about this or if you take care about this, you are going to have good result. You will be getting less complications. Like, what is hyperemesis gravidarum causing? First of all, it is pregnancy. Number 2, what is happening? The woman is immobilized by admission because of vomitings. And then number 3, because of hyperemesis gravidarum, because of repeated vomitings and not able to take orally, what is happening? She is having hemoconcentration. Now, these 3 high risk factors will predispose her to what medical condition? Just think, just give a thought. She is pregnant, she is immobilized, and she is having hemoconcentration. So, what is she predisposed to? Yes, it is thromboembolic phenomena. So, this hyperemesis gravidarum woman is at increased risk of thromboembolic phenomena. So, what precaution you are going to take? In your orders, either you will start with IV heparin, or you can go with stockings. This is what it is called? This is thromboprophylaxis. You have to initiate thromboprophylaxis in a woman who is admitted for hyperemesis gravidarum. So, to avoid this thromboembolic phenomena, suppose she was admitted with hyperemesis gravidarum, she was having all those complications, you rectified them all, and now again there is some another complication which is because of thromboembolism. So, you are going to prevent this. This is for prevention. You have to be vigilant, you have to keep this in mind that she is at increased risk of thromboembolic phenomena, and you have to include this in your treatment protocol. So, this is important, never miss this in this condition, because she has 3 high risk factors that I stated just now. And what else? If she is having hyperemesis gravidarum, severe form of disease in this pregnancy, then she is having 20-fold increased chance of having this disease in her subsequent pregnancies. Okay. This is important. Suppose in this pregnancy she had severe form of hyperemesis gravidarum, and by how she underwent abortion, maybe because of some other cause, then what precaution you are going to take before her next pregnancy? You will do H. pylori eradication. You will be doing H. pylori eradication by amoxicillin and tinidazole and blockers, proton pump inhibitors, PPIs. So this is all about this hyperemesis gravidarum, what you should be aware of as when you are doing either MD, MS or DGO, or you are a practicing clinician. If you are a student, MD, MS or DGO, I would like to tell you that in your wards, you make a habit of following all these things related to this condition in a routine practice, so that it becomes a habit. It comes in your habit, and you don't have to take efforts in your exam. So you will be benefited if you go through the protocols, if you understand this, and if you don't miss all these small things like thromboprophylaxis should not be missed, differential diagnosis, you should not be treating pyelonephritis as hyperemesis gravidarum. So you need to make all the differential diagnosis. Also make a chart of hyperemesis gravidarum. You can make it and get it photocopied and put it in every woman's case history, which indicates her pulse rate, her output, her input, her number of vomitings and all other findings, her electrolytes at one chart. So in that case, at one glance you can know whether she is improving, whether your treatment is working or not, or you need to change your medicine. So these are very important practical tips that I would like to share with you, and make it a habit. You are in learning phase. Whatever you learn now, you will remember it throughout your life. This is for sure. So while you are in a learning phase, you learn the things that are required. You go with the literature in books and you follow them in your practice. You investigate the woman accordingly, and never miss an ECG if she is having low potassium in her electrolytes, and if she is severe, never miss an ophthalmological examination. Also get her ultrasound obstetric as well as whole abdomen to rule out either other causes of abdominal surgical causes for hyperemesis, for vomitings in pregnancy. So these are some basics you must know, and if you like the video, please subscribe to my channel and share the video among your friends. And if you have any queries, write down in the comment box and I will be replying you soon. Thanks a lot.